Welcome to today's episode, brought to you by the Women in Medicine Summit, a transformational CME conference happening September 13th to 14th at the Drake Hotel in Chicago. Engage in leadership programming, learn negotiation skills, receive on-site coaching and mentoring, and see who will win this year's I Stand With Her awards. This year, we're excited to offer unique programming that includes a special session on how using improv comedy can bring fun back into medicine. We also have financial sessions tailored to help you navigate the complexities of personal and professional finances. Discover ways to advance into leadership roles, combat burnout, and either reignite your love for your current role or find joy in a new career path. Don't forget our Friday evening gala, a highlight this year you definitely won't want to miss. Register now at womeninmedicinesummit.org and be part of the movement that is shaping the future of healthcare. Join us to network, learn, and celebrate the power of women in medicine.
Does the electronic medical record drive you crazy? Do you feel like a cog in a machine? Do you want to have more impact and more agency in what you do? Then you're going to want to tune into today's episode with my guest, Dr. Kalie Dove-Maguire. She's an emergency medicine trained physician who is passionate about leveraging novel solutions to have a massive impact. Currently, Dr. Dove-Maguire leads the electronic healthcare record product team at Carbon Health. Her team at Carbon was the first in the industry to incorporate large language model artificial intelligence into the daily charting for providers, nearly eliminating the need for manual note entry and allowing providers to focus on the patient in front of them instead of their screens. I thought we were years from incorporating this technology into the clinical space, and I am really excited to hear Dr. Kalie Dove-Maguire tell us that the future is here, and all of us should be demanding systems and be working towards positive change. This is exactly why I have this podcast, because this conversation left me excited and hopeful about the future. Tune in today to learn more about informatics and the future of healthcare. Welcome to the Revitalizing Doctor podcast. We interview trailblazers in medicine that embody the Revitalize Women vision to empower women to innovate and influence medicine, to value authenticity, respect, and work-life harmony. We recognize the challenges in medicine, and we're committed to providing coaching-informed strategies to help you go from surviving to thriving. I'm very excited today to have Dr. Kalie Dove-Maguire on the podcast. Thanks for joining me today.
Oh, thanks so much for having me. I'm excited to be here.
Your bio is so interesting, and I can't wait to hear about all the things that you're doing in the informatics world. And later, you're going to be speaking at this awesome well-being conference coming up in Temecula, California. But before we get into that, we like to start with the question, why did you become a doctor? So your doctor origin story.
Sure. So my doctor origin story starts in rural Eastern Washington State. And our family doctor actually was my mom's doctor, delivered me. And then he was my doctor throughout my life. And throughout the course of that life, the mentorship is what actually got me into medicine. So I expressed an interest and he offered me to come shadow him. And I shadowed him in the clinic and was blown away because I loved the problem solving, loved talking to people. And then the real thing that really there was no going back after this is when he let me scrub into surgery with him. And then I was just like, yes, this is what I'm doing for the rest of my life. And then went to med school and kind of battled between, honestly, family medicine and surgery, and finally settled in emergency medicine. And here I am.
That's awesome. And do you still practice emergency medicine?
I do. I don't do it frequently anymore. My main 9 to 5, which is really weird as an ER doctor to have a 9 to 5, which, it's never actually 9 to 5, but it's at least daytime hours, is at Carbon Health working on their product team. So it's more in front of a computer, but I still work at UCSF occasionally, and I still in the emergency department and still work at Carbon Health doing urgent care too.
Awesome. Well, I think many of our listeners, that's what they're going to be really interested in. I mean, I'm sure you're familiar as an emergency physician, burnout's really high. 65% of emergency physicians are burned out. And so many people are looking to develop a niche. So how did you get involved in informatics?
It's a great question. So throughout my career, I've always really enjoyed having these larger scale impact sort of projects, which I know that echoes some of your other guests that you've had on here. The hard part is like, I always did those larger scale projects throughout residency and medical school, but I always thought that those were kind of the periphery. And I was just focused on being like a badass clinician, ER doctor. And I thought that was going to be my entire job. So I took a full-time job at Kaiser out of residency and thought I was going to be a full-time clinician. And that was the first time where I hadn't had any of those larger scale impact projects. And in residency, I worked at the WHO for a little while and also did a large scale palliative care screening tool at UCSF. Both of those have a little bit of informatics sprinkled in there. And that was what I found out was actually the most fulfilling part of my job, is because I love seeing the patients one-on-one. But at the end of the day, you see 25 patients a day on a busy shift. Whereas if you do a health policy thing or work in technology, you can affect everybody that touches the EMR that you're working on. So that's where I was really interested in. And I actually jumped off of that kind of career train, quit my full-time job, went part-time, and really started developing that tech sort of side of my interest, and was happily able to marry the technology aspect and the clinical skills that I have, and being able to actually have that bedside experience and being forced to use the tool that we've all dealt with, those EMRs that clearly no clinician had ever been involved in developing. I really didn't like that. So I wanted to be part of the group of people that was making those design changes and software changes to actually help us do our jobs better rather than just put roadblocks in front of us.
That's so inspiring. And did you have to do any additional training? Did you do a fellowship in informatics?
Yeah, no. So I haven't done a fellowship in informatics. I'm planning on getting board certified with the grandfather route. So I've just done informatics work. In residency, I did a bunch of clinical decision support. And informatics right now is kind of a buzzy word, but it encompasses a whole bunch of different things. It can be anything from a tech savvy doctor to somebody who's deep in some of the interoperability standards and everywhere in between. And so I had just a bunch of on-the-job training. I did informatics when I was doing my clinical decision support work. And then at Carbon Health, I do a ton of informatics work. And I'm not formally trained. I just learned all on the job. And then I ended up teaching myself how to code along the way too, JavaScript and Ruby and a couple other things. I am not a developer at all, but I can do a little bit, enough to be dangerous, I guess.
Well, I actually love that you're not fellowship trained, and I am also not fellowship trained in simulation. So I wanted to, but my career started in the Navy, and that wasn't a fellowship that they really recognized or valued, unfortunately. But they kept giving me jobs that I did. Eventually I was like, oh, I have the title of a sim director. So I guess maybe I'm not going to do a fellowship since I have the title that people would then do a fellowship to get. And I talked to a lot of people about it, and they're like, you're already doing all the things that you would learn in fellowship. And it's not that I'm a lifelong learner. If you put me in a fellowship somewhere, I would totally love it. But I think we have to break out of that mold sometimes that, oh, if I get the fellowship, then I can get the job that I want. And I love that you just did the experiences, and we're smart. We're smart as doctors. We can learn.
I wholeheartedly agree. We are very good at learning things. And that's kind of what I banked on. I was I'm good at learning things. I'm just going to teach myself the things that I need to learn. And like you, I talked to a bunch of people. I was like, should I go and do an informatics fellowship? And they were like, you're already doing the job. Why don't you just keep doing the job? I do want to take the test and kind of have that brand associated with me. But I think at this point, that's all it is. It's just a brand. It'll help you, get a job if you want to, but you can also just do the work. And I think there's lots of avenues to be able to just do the work if you're interested in it.
Well, that's great. And I'd love to put in the show notes the information on how to apply for that fellowship, go through the process, because I think it's a ripe field. I mean, as emergency physicians and all physicians listening to this podcast, EMR is one of the top drivers of burnout. So we need more people. And like you said, informatics goes beyond that. There's so much more to it besides the electronic medical record. But I think we're really well positioned to be able to make things better.
Oh, yeah, 100%. And just the breadth of backgrounds for emergency medicine and family medicine, because you deal with pediatrics and pregnant ladies and old people and everybody in between. It gives you a really, informed perspective to be able to comment on. Whereas if you are very, very specialized, not saying that you can't do it when you're very specialized, but it's just a different background to be able to draw upon when you have the breadth of experience that we've had. And also as ER doctors, we've dealt with half a dozen at least different medical records. It's one of the reasons I refused to take a job because it was just set up for me to fail. I kept waiting for that EMR to just have some head bleed that I didn't recognize because it was hidden somewhere. And that actually informed a lot of my career decisions, looking at how bad it can be and seeing man, this could be so much better.
And I love that. We're not accepting that this is the way it has to be.
Yeah. And I mean, healthcare and technology is so far behind every other consumer technology. Your Uber app and everything is so much more advanced than anything that we usually use in a general hospital. That just means that there's a ton of opportunity for physicians and other clinicians to get not in the driver's seat necessarily, but definitely as a passenger and a very vocal passenger about how to develop these things moving forward, and in the driver's seat too, if you really want to.
So I've been seeing a lot of Carbon Health clinics around. We actually have one right across the street from my emergency department. What is Carbon Health?
Good question. So Carbon Health is it's a nationwide health system right now, but it's primarily has urgent care clinics, but it's also primary care and specialty care. We have a really great diabetes program as well as mental health, and we're expanding that as time goes on. And the real interesting part about Carbon Health is that it's a full kind of stack offering. So we have our employees, and we also have our brick and mortar clinics, and then we also have the software, and we have virtual offerings. And because we have this full stack offering, we actually have this great research and development relationship with our clinicians. So our clinicians see something, or we're monitoring kind of the data trends throughout our clinics, and we can immediately change our software to be able to address what the clinicians are seeing. So when monkeypox outbroke, Mpox had the initial outbreak, we were able to see that in real time, be able to put clinical decision tools into the software also in real time, and spin up within a week. We had a monkeypox sort of pathway that clinicians could go down and get encouraged to order the test if it seemed reasonable and things like that. But that full stack sort of offering and that tight feedback loop between clinicians and our R&D department is what makes us just a cool place to work, because the clinicians get that awesome feedback and we can kind of see that real time change. And I work in the clinic, so I have to work on the EMR product that I am also in charge of on the R&D side. So it's kind of I think Apple calls it dog fooding. You have to eat the food that you're creating. So I get both sides of the coin, and I'm very motivated to make our EMR better because all the minor clicks and the pain points I feel on a deep level. So it's nice to be able to be in charge of that, to be able to fix it as time goes forward.
I love that. And that ties into the idea that you probably feel a lot of agency, that, you're just not in the back seat of having to, take what other, annoying things happen in the EMR. You are able to harness agency that, okay, when I go back to my office day, I'm going to try to fix this.
Yeah, definitely. And there's the harsh reality of emergency medicine as well as research and development is you have to be really good at triaging things. And so there are some very irritating things that you really want to fix, but unfortunately there's 3 more things that are far more urgent that has to get fixed first. So I get to work in triage skills, both in medicine and in development timelines.
I love that. And reading your bio, you mentioned that Carbon Health is using LLM AI technology. Can you explain what that is?
Sure. If you haven't heard about AI lately, the LLM is what the large language model, and that's what is the underpinning of ChatGPT and all of these generative AI things. And you can think of it kind of like autocomplete on steroids. So these are models that are capable of reading and understanding text as well as generating text. And what we did at Carbon is we took this model and we now have it basically listens in on the conversation that you have with your patient while you're having it, generating the history. You can articulate your exam, and then you can tell them about your assessment plan. You're like, I think this rash is actually a fungal infection. I'm going to give you this medication for it. And if it doesn't get better, I want to see you in this amount of time. And then you can walk out of the room and hit summarize, and that entire conversation that you had gets organized into a SOAP note so that your chart is basically done before the patient leaves. And so now instead of having to interact with the computer screen the whole time, the clinician can actually interact with the patient. And the other cool thing is that it reinforces good communication between the patient and doctor. So there's sometimes like me or anybody, when you're tired, you might just kind of skip out some of the like follow-up things, just like slap the diagnosis and the treatment and be like, okay, do you have any questions? No? Okay, great. Bye. This one, actually, if you spend time talking to the patient a little bit more and explaining it, all of that goes into your note. And it actually saves you a ton of time and facilitates that doctor-patient interaction. That is the reason most of us went into this rather than actually having to write a note anywhere.
Wow. I mean, my sound editor needs to like drop some cool sound in here. what our sound will be when you drop some really cool knowledge. I mean, I'm sitting back a little bit floored because I've been reading a lot about the learned language model and thinking about how it will apply to healthcare, but thinking that, you know, we're decades between the regulatory hurdles associated with it and Carbon Health has figured it out.
Yeah, I mean, that's one of the things about working in a startup company. It's just there's a lot less friction. Working at like a large hospital and trying to implement even the smallest thing, there's a ton of friction. But depending on the company that you join, the friction kind of goes away. People can rally behind a cause or a new thing that we want to do, and it actually happens. It's kind of like early stage of COVID, where you're like, oh, we need this stuff. Like, actually, let's get it going and let's get it integrated and working. And fortunately, my colleagues at Carbon and I were excited about this from the get-go. And as far as the privacy standpoint goes, that's a lot of people are sometimes concerned about the privacy aspect, but these conversations are not recorded anywhere or kept any duration through OpenAI. So Carbon keeps all of the kind of medical PHI in-house and just generates the chart for you so that you can just review it. And with our first kind of push out to clinicians, this is live everywhere now, but clinicians are mostly accepting the chart as is about 90% of the time. And the people that edited it was mostly for stylistic things rather than like content, really, because the content that it captured was more than most clinicians have in their history. Especially for me, I will frequently like try to use acronyms and convey a history in as small amount of time as possible. And with this technology, it actually like picks up a lot more of the rich history and includes it in there. And it will still filter out like the small talk that you have with the patient. It knows that that's not really relevant. So it gets rid of that to prevent too much of a note bloat. But the actual content that it has is all medically relevant stuff. So you can change it for stylistic things. But in general, like it's pretty good at capturing what you actually said to the patient, which as a skeptic myself, I was blown away at like how decent this actually is.
And are you in control that you can turn it off? Like if somebody did want to talk about something really sensitive and they're like, I don't want this recorded.
Oh, 100%. Yeah. This is just a tool for clinicians to use. I kind of think about it like a backup camera. Like you don't have to use your backup camera. You can use the mirrors. You can look around. You can do everything manually. But man, if you have the backup camera, it's really, really nice to be able to see around the corners. So clinicians can choose not to use it. They can also choose to use it for half of the appointment and just edit the note manually for the other half. The physician's totally in the driver's seat.
I mean, it really does sound like the dream of what we went into medicine to do, was just to see patients and be able to talk and counsel them and not be whittling away on notes.
Yeah. And I think this is so I'm a pessimist by nature, right? I'm an ER doc that's always looking for the worst first. And I'm pretty sure Skynet will come for all of us one day. But before then, I'm actually very optimistic about AI in healthcare, because some of the first use cases are all of these admin tasks that really make us despise our job, right? Like you have like this vague 40-something with like chest pressure and maybe some pre-syncope stuff. Like that's going to take some mental energy to work through. And if you're interrupted by like the 2 workman comp forms that you have to fill out and the transfer paperwork and like the 2 notes from yesterday that you didn't get done, like that's all the stuff that bogs down your brain and your mental bandwidth. And so you don't want to be able to put my energy into that stuff, but I want to put my energy towards like the complex problem solving that I actually have to do for a complex patient. And so that's where like AI can really come in and just get rid of some of those like low level admin tasks. And the first one that Carbon's approaching is the note, but we have a whole list of other things to be able to kind of knock out next to make it easier for us to do our jobs.
Stay tuned. We'll be right back. Are you a physician mom with school-aged children feeling utterly exhausted? My friend Dr. Sheeta Shafee invites you to take a little time this summer to join her in a small, intimate group for meaningful conversations. Dr. Shafee is an emergency physician, coach, and mom to 8-year-old twins. She understands firsthand what you're going through. This isn't a pizza party or a yoga class. You'll meet for 2 one-hour sessions twice a month starting in July to help you move out of exhaustion, let go of mom guilt, and live a life you're not only proud of, but can truly enjoy. Connect with her on LinkedIn or Instagram at Sheeta Shafee to learn more. Sheeta is spelled S-H-I-D-E-H, and Shafee is spelled S-H-A-F-I-E. You can also check the show notes for a link so you can connect with her there as well. It's amazing. Yeah, I mean, I've had, a few people kind of joke with me that, oh, aren't you worried about AI taking your job as a doctor? And I'm like, absolutely not, totally not worried. What AI can do is none of the stuff that I want to do. And I really think there will be still enough people that are sick and injured, unfortunately, and we'll be able to take care of them better because we won't be bogged down by this very repetitive stuff.
Oh yeah, 100%. I think AI, I think about it in a few different buckets. Like one bucket is all the admin tasks, which, AI is going to be perfect at, and those will be the first use cases. And then I think about it as like the first order clinical decision support thing. So this is like when you're a cocky resident thinking you know everything and you can like treat a single disease. You're like, I got this. This like diabetes, no problem. I got this septic patient, no problem. Like it'll probably be able to help us with that. That'll like hopefully help us recommend the right antibiotic based on the indications and the GFR and pregnancy status and everything. Like those are kind of the first level stuff. But the second order things, like I remember again, like thinking I was this hot stuff resident going to go moonlight in this hospital in the Central Valley in California. It was really high acuity, really chronically understaffed. And I walked in and one of my first couple shifts, I had 3 active like codes kind of back to back. And the last one was this 30-year-old who came in hypotensive, febrile, frothing at the mouth with a wide complex arrhythmia. Like that's a data-free zone. There is no AI that's going to help you with that sort of thing. So the critical patients, the patients with multiple comorbidities that interact with each other, that's like AI is not going to help us with that. That's going to be a clinician thing, but we'll actually have the mental bandwidth to be able to address those things if we don't have to waste our time remembering the exact antibiogram recommended UTI treatment for, a 30-year-old pregnant female. Those are the kind of things that, I don't know, I think it makes my job way more fun if I can focus on the interesting aspects instead of the less cool parts of the job.
Absolutely. And I just think about, again, that bandwidth that it extends beyond the emergency department. If you're not so drained from your shifts, coming home, the recovery is better, to be able to access more of that creativity and optimism. We just commented on how pessimistic we are. I think we're pessimistic because our jobs, I don't want to be overly negative, but there's a lot of things that aren't working right now with emergency medicine. And so if this starts to free up and make our jobs better, I think we'll start to see physician engagement improve and that creativity to tackle the problems. Because man, there's a lot of problems right now.
Oh yeah, definitely. There's some shifts where it just felt like if you're like a Harry Potter fan, like the mentors were just like sucking your soul out a little bit slowly over time. And some of those like admin tasks just are so soul sucking that if we can like use a little technology to make it a little bit less soul sucking, that's like a huge win. One of the early releases we were beta testing this feature before we released it widely. And one of our clinicians had actually said, she was like, oh my God, like I left, and she's the primary care doc, right? So if she's like super busy, has a ton of patients left. And she was like, all my notes were done when I left. I actually could go home and had enough mental energy to like cook myself dinner instead of just scrolling on the couch. And other people have like said the same thing. It's like, I had enough energy to like work out instead of like just zoning. And I think that is like also really illustrative about the opportunity that this has just to make our lives a little bit easier.
That's so exciting. I'm guessing there's a few doctors listening that really want this technology in their EMRs. I've heard some whispers that Epic is doing this. if somebody's listening and they're like, well, I want LLM technology at my center, like what is some steps that they could start taking to make that happen?
Oh, that's a great question. Especially from the ER standpoint, we're all kind of beholden to the EMR that we used. And until there's like a third-party software offering where you could just record it kind of ambiently and import it into your note, which there are some software companies that do that. So you can look into some of those software companies, like Ambiance Healthcare is one of them. Epic is working with Microsoft to do a integration through Nuance. So the like Dragon dictation stuff, I think they're working on incorporating that. So it might actually come to Epic soon. And then as far as kind of getting into the driver's seat, because it's not released yet, I'm not really sure how they're going to be integrated into the EMR or if you'll be able to use them like off the shelf. You know, like a lot of us are kind of hired guns, right? We go and do locums or something somewhere else and we're kind of beholden to whatever EMR exists. I think it would be really cool to be able to have one of these where you just have like your charting assistant where you can record any conversation, have it generate a note, and maybe you just copy and paste into your EMR, which I think would be super cool, but doesn't exist right now. But there's lots of opportunity to be able to do this. Back to your original question though, how do you get it at your shop? Figure out who does your tech lead, depending on, this might be like a chief information officer is usually the main title that people have at hospitals that do this. So they would probably be in the driver's seat, or your medical director might be able to have some sway here too. It depends on kind of the structure, but the information officer or whoever does your information stuff will probably be able to have insight into whether or not you are planning on incorporating this into your stack or not. Because I'm sure it's going to end up costing more money. So I would just advocate for it because this is going to do so much for burnout and actually improving the sustainability of our jobs.
Do you have any sense right now about how susceptible it is to noise? I mean, knowing that the emergency department tends to be a really noisy place.
Oh, yeah. Good question. Yeah, we've only tested this in our clinics, which are not the ER. We have like one-on-one patient rooms. So it works well for our use case, but we haven't tested it in the ER. So I'm not really sure. But that said, a lot of the technology and the microphones these days are so good at filtering that stuff out. I don't imagine that being the limiting factor. Like, I think as long as you can pick out the two main voices of the conversation, and most of the transcription software is actually like pretty decent at this. You can imagine like Alexa and everything, like Alexa can hear you over your kid screaming and stuff when you talk to her. There's like a lot of great technology around to be able to actually pull this off in the ER. I don't think that'll be a limiting thing.
Awesome. Well, I want to pivot to talking about the Wellness in the Vines conference. Can you tell us a little bit about that?
Sure. So Farzad knows far more about it than I do, but the focus of it is about physician burnout and improving wellness in our clinicians. And around that is trying to be more resilient kind of emotionally, physically, and financially. And so the lineup looks really interesting. And I'm excited to be able to go and hear some of the other talks because they look really interesting. It's in Temecula, September 17th through 19th.
Awesome. And are you going to be speaking at it?
Oh, good point. Yes. So I'll be on one of the panels for, I think, atypical careers in medicine. I think it has a different name than that, but I'll be speaking to having a kind of non-traditional clinical adjacent career. And I think there'll be a handful of other clinicians that have had similar like forays in medicine and outside the department.
Amazing. So if somebody's listening to this and they're thinking about like, well, maybe I want to get more involved in informatics, because I mean, would your prediction be that with the expansion of AI, and that's certainly only one component of informatics, do you think that this is a career path that's going to need more physicians?
Yeah, I think it'll definitely need more physicians, but I also think it's going to be one of those things where if we don't stand up and have conversation, like if we're not part of this conversation, it's going to happen without us. So we need to be advocates for ourselves here. And so if you're interested at all, like 100%, like take a course online, get a little bit savvy about some of the words that people are using, and then like step up to the plate. Like if you have a tech group at your shop, like sign up for it. If you don't, then like be the person that people ask these questions to so that you can actually be a voice and kind of represent it to other people. And if you want to do the full informatics like career route, by all means. But if you just want to dabble first, there is so much like online education about this stuff that you can like take an online course in your spare time and just figure out if you like it or not before you kind of completely dive in. But yeah, healthcare is so far behind technologically than any other industry that there is so much opportunity for us to actually like make tools that make sense for us. And I think the tools will get made, but whether or not they make sense for us, it kind of is dependent on whether or not we're actually at the table having these conversations. So yeah, get involved, get savvy.
And reflecting on your career path, and that now you kind of mentioned that you have more of a 9 to 5 job with Carbon Health. And then before I think we started recording, you mentioned you have a little one at home. Is that right?
Mm-hmm. Yeah. I just had my second child. Yeah. So I have 2
wow.
ones at home now.
Yeah. So do you think what we see a lot right now, well, there's actually a paper that just came out that women emergency physicians are leaving the field about 12 years before their male counterparts. Could you talk a little bit about your journey to kind of a more stable schedule, and or if there were any other things that kind of, you mentioned it was certainly the purpose and meaning to having a bigger reach, but were there any other factors that affected your career transition?
Yeah, it's a great question. And I think like the primary thing that really drives me is that kind of intellectual curiosity and problem solving. Like I need to be stimulated. And so the larger scale sort of projects plus the tech intersection is just like very intellectually stimulating for me. And I love learning new things and trying to problem solve in a different way. So that's like the primary driver. But on the other side of that, the benefits that I've had, like being able to move from, I was working primarily night shifts. I was pregnant during the first wave of the pandemic. So I was like in full PPE, very pregnant. And then I was breastfeeding also in full PPE where you like can't drink any water, just like a very hard sort of like workplace environment to be a mom in. And I've always been like a really tough person who's just like, just do it anyway. Like put on your big girl panties and like go forward and keep doing this. And so like I did that for a long time. But when I had this career opportunity come up, I said yes to it. And the change has been really, really awesome. Like I will still pull shifts in the ER, but this is like the 9 to 5, like, I mean, 9 to 5 is like a farce, but my daytime work schedule, you know, it matches my family now. It matches the rest of the world. And I didn't appreciate how much of a like lifestyle factor that would be when I chose emergency medicine. Cause I originally chose it and I was like, yeah, nights, weekends, holidays, no problem. I'm like 26-year-old that has endless energy, or, you know, 20 something when I chose it. But now having a schedule that's a little bit more predictable has been really like mentally healthy for me. It's hard being a mom to young kids and pregnant and stuff in the ER. And I wish it wasn't, but this is much easier now. Never easy, but man, yeah, I wish it was more sustainable to be able to do the ER work.
Yeah. And I think there is a way for us to get there. You know, I think when you look at what's coming into the emergency department right now, there's a lot of things that could be managed in clinic and urgent care during normal hours. It really could. But our system is just so dysfunctional right now that patients can't get into primary care. You know, some can't get off from work. There's a myriad of different things. So, you know, part of, you know, our model at Revitalize is encouraging career diversification, having options. You know, I would still encourage people to keep their board certification in emergency medicine. One of the past guests we've had on talks about doing 1 shift a week, which works for her. And she's a practicing attorney. Same time, she's her MD/JD. So I think I would encourage people to keep their options open. And even like my career path now, I'm recording this from my sim lab. I joke that there's no emergencies in the sim lab and that, you know, it's Monday through Friday. I don't work weekends. I still work some nights and weekends in the emergency department, but far fewer. And doing 1 night shift a month or 1 every other month is way more sustainable for me right now.
Yeah, definitely. And I think, I mean, like other professions have this figured out, right? Like the nurses and everything have the same kind of schedule that we do, but depending on the shop that you're with, then the way that the schedule is built and what amount of flexibility or lack of flexibility exists there, or predictability, I think has a big impact in a lot of humans that need to have a little bit more predictability. So even if it's crummy hours, if it's predictable, that's super helpful. But I think historically, that hasn't been a top priority in a lot of shops. So I think kind of moving to a more sustainable, like career longevity thing is going to need to have some changes from the administrative side of emergency medicine, as well as like what you can do personally right now to make your career a little bit more sustainable, which I 100% agree is like diversifying your interests a little bit so that you can, have a space for you to rejuvenate before you come back to the department.
Yeah. And I mean, we like to say that COVID was all bad, but what was not all bad about COVID is it did force me to diversify a little bit. I knew I was leaving the military, and it became very real to me that I needed to make money. I would not get a paycheck on the 1st and the 15th as I did on active duty. And so that was my first little dabbling in telehealth, because I was like, okay, well, if I test positive for COVID or I'm exposed, I'm quarantined, the good old days when you used to be quarantined, I'm going to be off. If I'm not feeling sick, could I still do telehealth? And so that was my first little foray into that. So I think, exploring options and trying to build in some options that if you are particularly sensitive to the night shifts, the challenges with scheduling, what could you do that would add some regularity into your life? I love hanging out with my husband at night, having dinner. And I actually like getting up at the same time every day. And I'm not 100% there, but I'm probably like 50 or 60% of the way there.
Yeah, the physical health aspect of night shifts and the taxes that it takes on you are like pretty substantial. And I mean, there's a lot of medical literature to support this, but I think so many physicians just have that kind of a martyr mentality and like, we don't need sleep and we don't need to eat and we don't need breaks, but we are human and we need all of those things.
Yeah, absolutely. So on that note, what do you do to stay healthy?
Oh man, not enough right now. I chase my toddler around to try to stay healthy. I like cooking a lot, but now having 2 kids, it's a lot more challenging to actually like cook to make meals for us. So I have to get a little bit more creative. I used to mountain bike a lot, but again, like the kids kind of put a cramp in that dial. So I'm trying to be more physically active. But again, like just sleeping has been pretty huge, but baby steps. I want to go back just with one other thing that you said about the career sort of aspect. My husband always says that like careers are nonlinear. And I think that's a really great piece of advice because in medicine, we always think the careers are linear. We did the med school, we did the residency, we did the maybe fellowship, we did the best job that we could get after that. And like, it is 100% okay to like take a break or deviate and come back. Like, I think there's a lot of fear about like jumping off that track or like choosing something different for a little while. But just because you choose something different for like maybe even a year or 2 does not mean that you can't come back. Like every shop that I have said, like, I'm going to take some time off. They're like, just let me know when you want to come back. Like, I don't think there's a huge risk for like not being able to return to clinical medicine as long as you keep your skills up and that sort of thing. So if you're curious about trying something else, don't be afraid. Like, I think it's great to be able to explore other things. And we're fortunate enough to have like this great skill set that is applicable in many different domains.
Yeah, I love that advice. It's kind of, a well-kept secret, or maybe not that well-kept, that sometimes going per diem, you actually have a lot more control over your schedule, which may be frustrating to some of the full-time people out there, but it's something to think about. And I think in the way things are moving right now, there's all this fear that there weren't going to be ER jobs. That workplace report came out. It's like, oh, the sky is falling. Everywhere I work, they want me to work more. There is work coming out of our ears. So I would say harness your agency and put some boundaries around what's okay for you and your family right now. And you're going to have work. You really will.
100%. I had the same thing. I was like so scared, it was like the work is going to disappear, but man, there is a lot of work. And one of the things that like helped me like recover a little bit from some of my burnout is actually becoming a little bit more selfish around my time. Whereas like I started and people would be like, oh, we had these open shifts. And I was like, okay, we gotta band together and like work these open shifts. And that's great to a certain extent, but like you have to have time to like recover. And for me, I needed time to recover. So I needed to give myself permission to like not pick up those open shifts and like actually be really protective of my kind of downtime so that I would actually be able to return to my job and have the energy to be there. Yeah. Like fully present as opposed to just cranky and pissed that I was there. Being protective of your time is really important, at least for me, to help with the burnout aspects.
100%. And I hope people are listening to that loud and clear. There are so many incentives for people to ask you to work beyond what is sustainable. But at the end of the day, you're the only person that truly knows your life. And it's okay if what you need is different than somebody else.
100%. Yeah. We don't have to be the martyr. It's fine to do this for the long game. Like, this is a marathon. It's not a sprint. So we have to be able to protect ourselves enough now so that we can keep doing this in, 5 or 10 years from now.
Absolutely. Well, this has been such a wonderful conversation. I'm going to be at the Wellness in the Vines conference. So Revitalize is going to be exhibiting there. And so I'm hoping that a lot of our listeners will sign up. I know we've got quite a few listeners in Southern California. And if you're listening from outside of Southern California, we're a great place to come visit. Temecula is a wine region, plenty of great restaurants. There's tons of great events planned. How can our listeners connect with you if, they'd like to find out more about what you're doing, and how can they reach out?
Well, we can hang at the wellness retreat, definitely. And I'm excited to see you in person too, as opposed to just virtually. For those of you that aren't going to be there, you can find me on LinkedIn. It's Kalie Dove-Maguire on LinkedIn. It's pretty easy. My name is spelled Kalie. That's the one hard part. You can email me, kalie.dove-maguire@carbonhealth.com. And feel free to cold call me or cold connect with me on LinkedIn and send me a note. I've had a number of people do that are just like, hey, what is this career you have? And I've ended up meeting lots of really cool people. And in general, if you are thinking about diversifying your career too, definitely stalk people on LinkedIn and reach out. Like, most people want to help. And if you see somebody with a cool career or like a cool side hustle, like, just ask them. Most people are really receptive. At least I've found when I have reached out to people, and when people have reached out to me, I'm more than happy to have a conversation with people. And I know others are as well.
I love that. And that's what I have found over and over again. When I started this podcast, I was so intimidated. Like, there's no way I could, get this person on my podcast. And for the most part, people want to come and they want to share. And everybody understands that medicine's hard right now. So I think you're in the larger group. I mean, you're a doctor, and other doctors want to help other doctors. And business people think we're cool too. They think we're really interesting for the most part. So yeah, expand your network, make that LinkedIn message or whatever it is, and join us in Temecula, because you're going to meet Kalie, you're going to meet me, you're going to meet my colleague, Myriad, who was featured as our first male ally on the podcast. And so I'm really excited for this to be an in-person gathering that will have a lot of really great women and a lot of great allies that we can all get together and come up with ways to make our lives more fulfilling.
Yeah, I'm really looking forward to it. And to double down on that, I used to think networking was a dirty word. It is 100% not. Like, just go out and talk to people. Everybody is happy to talk to each other, but don't be afraid of the networking aspect of it. I used to think it was like smarmy and weird, but turns out it's just having conversations with people. And we do that every day, like completely blindly every time we see a patient. So you're really good at it if you actually kind of lean into those skills.
I love that. We talk about it at Revitalize that women physicians often don't want to network because of the exact words you just said. And it's like, trying to make a toddler eat their vegetables. But we sometimes change out the word from networking to connecting, because women are inherent connectors. We know how to figure out, if you're a mom, like, what's the breastfeeding policy? What daycare should I be sending my kids to? What's the lowdown on the school district and this? So just transfer those skills and just change out networking to connecting. And it's so cool. Like, the first time that my favorite thing about networking was somebody that had always helped me, that was a sponsor, more established in the field. And the first time he reached back and needed my help connecting to somebody else, I was like, oh, I think I'm I'm an adult at this table now. And it was just like so wonderful to finally reciprocate and realize that I've got this great network that I could help him out as well. So it is fun. And that's why, I hope to see many of our listeners at Wellness in the Vines. And then for emergency physicians, The American College of Emergency Physicians meeting will be in Philadelphia this year. And spoiler alert, listeners, there will be a very special Revitalize event that we'll be sharing with all of you soon. So, well, Kalie, it's been great having you on the podcast. Anything else that you'd like to share with us, or we'll see you in Temecula?
No, that sounds great. I'm looking forward to it too. One other thing from the ASAP aspect, there's a Hacked ED component of ASAP this year, and they have a virtual speaker series as part of that. And I'll be speaking in that virtual series. And then there's a in-person Hacked ER aspect of it too. So if you're curious about startups or more innovation stuff, definitely check out that aspect of ASAP as well.
Oh, that is such a mega pearl. We'll be sure to have that in the show notes, and I'll probably put that in our Revitalize newsletter, because I really do think ED docs are all doctors. Obviously, my tribe is most closely aligned with ED docs. I think the time is now. Let's get into this tech space. Let's disrupt with purpose. We understand what patients need and what our colleagues need best.
Definitely. Yeah.
Well, cool. Thanks, Kalie. Can't wait to have you back on. We just got the surface level of, I want to deep dive AI more, and I want to learn about other aspects of informatics, because I think there's a lot more to touch on.
Yeah, I've been deep into AI stuff lately, but yeah, I'm excited to talk about AI in the future, AI present, other informatics stuff. Anything you want to talk about, I'm open to.
Well, thank you, Kalie.
Thank you.
Thanks for listening to the Revitalizing Doctor, a project of Revitalize Women Physician Circle. Our mission is to connect women physicians and allies through innovative, value-based coaching methods that align trust, support, accountability, and skill development to ignite the courage and clarity necessary to take bold actions, create change, and thrive. If you're interested in working with us, check out our website at peoplealwayshcc.com/revitalize or email us at revitalizeimm.info@gmail.com. This podcast represents the views of our host and guest. It does not reflect the views of any institution we work for or with.
Hi, it's Dr. Risa E. Lewis, dropping in to tell you about a book that Dr. Adara Landry and I wrote. It's called Microskills, Small Actions, Big Impact. It's a business self-help book coming in 2024 by HarperCollins. Pre-order now. Microskills, Small Actions, Big Impact, wherever you buy your books.